Good morning, everybody. And at the very offset, I'd like to thank the organizers of the 4th International Pediatric Endocrine Society of Bangladesh Conference. I would really like to thank Professor Rabi Biswas and Professor Saida for really providing me this opportunity. And I'd like to express my apologies for unable to attend the conference because of pressing personal reasons. And in the field of pediatric endocrinology, there have been a huge technology revolution which has happened right from the availability of physiological delivery systems for diabetes like automated insulin delivery, novel therapeutic options like molecules which are really designer in terms of insulin, in terms of GLP-1 receptor analogs which are available, which have widened our net of therapy, resulting in precision medicine and precise diagnosis. Despite so many developments that we are having in terms of pediatric endocrinology, there are still problems which are happening in terms of missed evaluation. 15% children in our clinics are still coming to us as short adults. There are protocol deviations in many of the emergency settings, and this results in high mortality and morbidity. There are primary care errors which are there, which result in unnecessary workup where it is required, and delayed referral workup is not done when it is definitely required in that regard. So there's a 4-year lag in terms of treatment of Indian children as compared to their Western counterparts for growth hormone. So clearly, there is a issue which is there in terms of day-to-day management, and whether technology can help us or not is a key question in that regards. So over the next 20 minutes or so, I'll try to see how technology innovation can help us in pediatric endocrinology to diagnose conditions, to interpret complex diagnostic issues, to manage disorders, and to decide at a point of care to really lead to a particular management strategy from that perspective. So this is the issue, how technology can help us not only do all the fancy stuff, how it can help us in day-to-day to a pediatrician who is practicing at the level of a rural center, at the level of a district hospital, at the level of a university hospital. So across every board, the decision making becomes rational, evidence-based from that regards. So let's start with the most common case which any pediatrician will see, particularly from a pediatric endocrine perspective, a child with short stature. So this is a 12-year-old girl whose height is 120 centimeters, weight is 15 kg. What should we do? Now, when we really think that this is such a simple thing, there have been hundreds of classes which are being taken on short stature. A lot of awareness programs have been conducted. But when we really looked into how our pediatricians and pediatric trainings are faring in terms of case-based scenarios which were presented to them, what we found was really astounding. So a large number of scenarios, there was missing of pathology. On the other hand, many physiological cases were being labeled as pathology. So therefore, there was clearly a missing or messing which was happening in a large proportion of these cases. So what can be done to improve that? When a clinician is making a decision with regards to management of a particular disorder, they combine the clinical and laboratory evaluation and then try to look at what the evidence is, develop their own algorithms, and finally resulting in a particular recommendation. Now, this is easier said than done because evidence is changing, and every year thousands of papers are published, and most of the busy clinicians don't have time to really spend and evaluate from that perspective. So what options we have? We can have a clinical experience looking into that regards, but that is prone to bias. I always think that this is celiac disease. I don't want to evaluate for something else. They are unpredictable because in different scenarios, they will not do the same thing. Humans are known to be variable in that regards, and often they tend to be static unless and until we have many more conferences like this. And if you look at the amount of practice change with papers, with publications, with conference and workshop does, it is quite minuscule. So this is something which is difficult to handle from that regards. The other option is automated decision tree, in which there is uniform management as far as an algorithmic fashion. However, this is a problem of being rigid, but this can be changed based upon newer evidences as and when it becomes available. We also have options of artificial intelligence in this day and era, which can be contextual, flexible, but would require a large amount of data to really reach a particular diagnosis from that perspective. So pediatric endocrinology, however, is one branch of medicine which is amenable for a lot of technological interpretations and management because we have algorithmic evaluation. We have got clear-cut protocols to assess, decide, and interpret investigations. There is a definite potential of intervention in most cases, and objective management is available. So based upon these, we got stimulated into starting a decision tree, and we decided that the most easily available device for any clinician in this day and era is a mobile app. So if we are able to develop a mobile app which functions on across platforms, which provides offline user access and which provides point of care guidance, this could be something which could be helpful. So we developed the MedEClasses Endocrinology application, which is the widest, most downloaded endocrinology application across the globe. Wherein we have provided approach pathways which go in an algorithmic fashion, allowing assessment management pathway which take through different steps of management. Also, assessment of complication things like bone age assessment, and finally interpreters in which just putting some entries you will get the localized log likely outcome in terms of evaluation and guidance from that regards. Our first study on this regards was that for short stature, which was clearly the most common. So we developed this algorithm based upon multiple guidelines, giving priority predominantly to clinical patterns. So what we are looking here is to look at height standard deviation score, followed by corrected height standard deviation score for familial short stature, height standard deviation score for bone age for CDGP, and then only we go ahead in terms of evaluation. So what the clinician has to do is to just put some data. Based upon that, all the interpretation is done and likely diagnosis, evaluation, and management is suggested. And what we found was very encouraging. This a paper published 4 years ago in JPEM showed that there was a 98% concordance with the gold standard clinical diagnosis with the use of app, and we had the potential of reducing these complications from that perspective. We then extended this to obesity, again focusing on key clinical parameters, and this has been our theme to not overburden with workup right away. So for obesity, we are talking about clearly, of course, categorizing based upon the BMI or weight or height SDS, looking into the drug history, clinical features, vision, development, and phases, and then decide about workup from that perspective. All the clinician has to do is to just to tick a few boxes, and within a few seconds, they will get estimations and get the right diagnosis from that regards. And again, what we found that the concordance score was huge compared to the trainee and the pediatricians who would have benefited quite a lot with the use of obesity interpreter. Now, another situation which we see, so this is a 16-year-old boy with polyuria, there is hyperglycemia, and this is an unfortunate case, that's why I'm highlighting it, had a high HbA1c, managed with DKA, on insulin the requirement became less, the child was slightly obese, there was acanthosis which was there, BMI was on the higher side, there was the family history, and based upon that, the clinician decided that this is not type 1, this is type 2 diabetes, and we should stop insulin. Now, what we need to remember is that now there is increased prevalence of obesity in type 1, and unless and until we have done an autoimmunity assessment, we have no business of stopping insulin. So what we did was to develop a diabetes interpreter, which was basically working in terms of algorithmic way based upon the criteria from the ISPAT guidelines largely and our local parameters, looking at three major things: the age of onset, less than 1 year for genetics, 1 to 2 years, largely type 1 as default, and above 10 years, depending upon the scenario, to look at the weight, BMI, presentation as DK, and then think of autoimmunity. So this was a simplistic tool recently published in Indian Journal of Pediatrics. And what it does is that based upon just a few parameters, the clinician will get what is the likely diagnosis, whether a workup is required, and if at all, how do we go ahead in terms of evaluation and management. And what we found when we compared the tool's guidance to the gold standard, the pediatrician, the trainee, pediatric endocrinologist, and endocrinologist, we found benefits across all domains. So of course, the pediatrician and trainees had a very, very poor outcome in terms of response. But when we look at the endocrinologist also, the adult endocrinologist was diagnosing type 2 very easily, but they were missing on autoimmune evaluation. They were also doing a lot of unnecessary autoimmunity evaluation when not required. While the pediatric endocrinologists were diagnosing type 1 well, genetics forms well, they were missing on the type 2. So this is something, a clear divide across domains. There could be benefits which can be identified from that regards. Similarly, we have developed a puberty interpreter, and this puberty interpreter clearly has been shown to have a very good outcome as far as the decision approach. And very importantly, when we did our economic study this time, we found that the use of puberty interpreter would have, just by reducing unnecessary investigation, saved over 200,000, 2 lakh rupees for the trainees. And there are, of course, benefits of evaluating when it is required also, which is there. So this is one tool which can really help out. So we now have interpreters across all board, thyroid interpreter based upon thyroid function, which can just be done. We have hypoglycemia interpreter. We have got calcium and electrolyte interpreters pretty much covering the entirety of pediatric endocrinology with age specific guidelines, with specific parameters, assessment, all units, which will give us a clue. So this is, in a way, the entirety of these algorithms are part of these applications, make it very easy for point of care guidance in that regards. One area which is quite complicated is disorder of sexual development. So this is a 14-day-old child with DSD who had palpable gonads, advised female rearing, and reassured presented with salt wasting. And this is one area which is both medical and social emergency, wherein we need to really work out in terms of evaluation. So we developed this algorithm, and this is the paper which is being published in Indian Journal of Pediatrics. We use this complicated algorithm to look at, classify largely based upon gonads and Mullerian structure, and then further classification based upon testosterone for XY-DST, 17-OHP for XX-DST. Now this looks very, very complicated, but the application is very simple. So what you do is that as soon as you put the data, you will be asked specific questions and investigations only for the conditions which are relevant. And based upon that, it will give us the diagnosis as to what's the likely diagnosis, what is to be done, and how do we manage in that regards. And again, substantial improvement in terms of diagnosis as well as initial diagnostic plan compared to the pediatrician, the pediatric trainee, and the neonatologist, which were observed with the tool. So clearly, we have now seen how automated decision tree can help in terms of pediatric endocrinology. What about artificial intelligence? How can artificial intelligence help out in that regards? Now, artificial intelligence is a very broad term which encompasses everything, which includes a group of things called machine learning, which is a simplified assessment in which you just use some algorithms, classify, some features are extracted, and you get the output. Machine learning, simple, it requires less amount of data, but the problem is that it will not be good for complicated tools. So now what we are looking at in terms of that is tools which are better. So our conventional tools like Netflix or Siri, they are working like a machine learning. The next step, of course, is deep learning, which involves multiple inputs, the convoluted neural networks which are connecting to each other to get a better outcome from that regards. These are complex tools, larger data are required, and they are, of course, slower from that perspective. One way of doing it is something like the phase 2 gene, which is basically looking at the facial dysmorphism and telling us as to what we are looking out from that regards. And then finally, the holy grail of artificial intelligence is generative AI, which is basically looking at putting in a lot of information that is there, and based upon that, thinking of itself, coming out with responses are typical large language models like ChatGPT work in that regards. Now, how do we decide to develop a clinical decision support tool in artificial intelligence? First of all, you need to have a huge amount of data. So if you want to develop a tool for disorder of sexual development, you will need around 8,000, 10,000 case scenarios with all the workup which is available. Around 80% of that will be used to train the model, and then 10 to 20% will be used to really test the model and validate and decide on that regard. So this is a complicated process. This process requires a large amount of data, and because it's not available, it may not be feasible, at least at the moment. There are already ways in which people are synthesizing data artificially to get it done, but this is something which is a work in progress in that regards. So this will give us a very collaborative, collective, point-specific investigations and guidance, because often every child doesn't come and follow the algorithm. So in that scenarios, AI would be helpful. Just to illustrate, this is an interesting study from China, which looked at a dynamic uncertain causality graph to look at overall the performance of their AI-based tool in terms of assessment of DSD, similar to our DSD interpreters. They had 94% accuracy, which were higher compared to interns and third-year residents. The problem is you need to have a large amount of data, particularly for rare disorders. It may not be easily available. So in that scenario, still the decision tree approach looks quite reasonable in that regards. So clearly we know how to diagnose. Now interpretation is an important part of pediatric endocrinology. So this is a child who was referred to us for evaluation of growth hormone therapy, particularly in that regard. So that the parents had been told that the bone age is 14 years and growth hormone treatment was recommended. When we redid the bone age, it was found to be 10.5 years, and clearly there was no need of growth hormone therapy. Now, this is not something unusual because we see so many reports of bone age which are erroneous, which are very wide, which don't make big difference in that perspective. So there are multiple methods available like Rulish File, Atlas, Tanner Whitehouse, and Bone Expert, but often the pediatricians don't have the expertise, the time, or the money to rely on these bone age tools from that perspective. So what we did, we developed a mobile application based bone age tool which looks into 5 key sites, the 5 major sites of Tanner Whitehouse, and we compared that to gold standard. And what we found was that there was a very good collaboration with regards to the bone age assessment, and this tool is now available as part of our MedEClasses application and is widely used globally to assess bone age. It is much quicker compared to Tanner Whitehouse, maybe around 20% time only is required. We now have also developed artificial intelligent convoluted neural network based approach, which is calibrated to local data in which you will get the results instantaneously within a few seconds in that regards. And this has been shown to have very high levels of mean absolute error as well as lower calibration from that regards. Similar tools, as I discussed, have been developed in which you can take a picture of an individual and look at the possibility of a clinical diagnosis. This again is something which is quite interesting. You have a complicated case, you just take a picture and you will get the likely diagnosis from that regards. Very interestingly, while we are assessing at an X-ray or radiologists are looking at a CT scan, we are looking at few patterns. AI may be looking at number of things. So there are now tools which are looking at a CT scan, and based upon that, even without a single biochemical test, telling us the possibility of whether this is a secretory adrenal tumor, whether it's going to secrete aldosterone, secrete androgens, or maybe catecholamines. So even without a biochemical testing, we are able to get the diagnosis. And this is a wonderful confusion metric that we are looking at in that perspective. There are also ways in which things like getting an ultrasound done to look at thyroid malignancy risk. And clearly what has been shown out is that using an AI model, one can really identify even with a poor quality recording to get a right diagnosis from that regard. So clearly, the artificial intelligence based techniques are going to go a long way in terms of assessing and interpreting results from that regards. Another very interesting finding which I found was this study in which the change in voice without IGF-1, without growth hormone level, predicted the chances of acromegaly. So these are very good screening tools which can be applied to identify patterns, make diagnosis, which may then be confirmed precisely in that regards. Now, coming back to our own approach, we decided that now we have enough algorithms for growth, puberty, and obesity and bone age. Let's combine it into one tool, which is bone age assisted interpretation of growth. So what this does is that the clinician has to input basic details about the birth weight, the height, weight, parental height, fill the comparison as far as the bone age and the puberty assessment, and one will get a real data in terms of the likely diagnosis, the evaluation, a lot of parameters come up, and also in terms of what should be the workup in that regards. And the use of big or bone age assisted interpretation of growth is associated with substantial improvement in concordance rate and 96% reduction in discordance. So this is something which we are very interesting, and we launched it very recently as a web portal. So we have now discussed about diagnosis and interpretation. How about management? And there are multiple scenarios where management can go haywire, particularly in areas where they don't have access to pediatric endocrinologists. So this was a 4-year-old girl with DKA, managed with fluid and insulin outside, developed hypokalemia. In treatment was given normal saline followed by insulin, and the child developed arrhythmia. So this is not an uncommon scenario, and this is because of lack of implementation of protocols. Now, this is our own data, which we published a few years ago, where we found that despite a written protocol, despite multiple sittings that we do, a lot of errors were happening in DKA management, and they were resulting in the development of hypokalemia and hypoglycemia. This is something which could have been prevented. So what we did was that we went ahead and developed a complicated algorithm based upon the ISPAT guidelines, and based upon that, the clinician will get clues in terms of what they should do in terms of initial management of DKA, as well as the follow-up management of diabetic ketoacidosis from that regards. And this tool has been shown to decrease the discordances which are happening and improve the outcome in that regards. Another scenario of this 14-year-old boy with type 1 diabetes developing seizures and hypoglycemia despite being on a good analog basal bolus regimen, had a poor control. The child was not carb counting and adjusting the dose. And we know that carb counting is important and that improves outcome. But there are problems and obstacles. There's so many food which are there, how to carb count everything, how to do it every time, do calculations. So we have developed a mobile application based tool, Diabody, which provides guidance about insulin dose, tracking of glucose, activity, sleep, eat, and sick day management in type 1. And what we have shown is that once these data are filled in, we have developed a large database of various food options which are particularly locally available. And once the child is able to put those items and put in perspective, they will get guidance as to what should be their basal dose, what should be their bolus dose, and based upon all the calculations that we're talking about are already done by the application, and they will immediately get an outcome in terms of the doses which are required. The use of the tool has been shown to decrease the errors which are happening in terms of the insulin dose, in terms of the variation that we are seeing. And also what we are seeing is that there is improvement in terms of the HbA1c and in terms of the delta rise of blood sugar. So this is something which is going to help out right at a clinical perspective, along with improvement in quality of life and very high level of satisfaction scores which we were able to identify. Another scenario which we often found challenging was that of sick day. So this child with type 1 diabetes with stable control had febrile illness, developed diabetic ketoacidosis because of inadequate sick day management. Again, not something which is uncommon. So we use Diabody, in which we have an algorithmic approach to decide about what should be done in terms of need for admission, in terms of extra insulin dose, in terms of monitoring, and found substantial improvement across various platforms from that perspective. AI and technology-driven strategies have now been developed, which will help us evaluate in terms of the proper assessment, in terms of the various dosage for various endocrine conditions as well. What about decision making? So often, even as experienced pediatric endocrinologists, we do encounter some complicated cases like this failure to thrive with pigmentation and hepatomegaly, with hyponatremia and abdominal calcification. So we might be bowled out on that. The options include go to a textbook, read it in more detail, and that of course is something which you will not be able to read the diagnosis quickly, to go for e-resources which are available, learning portals like MedEClasses that we have developed. But ultimately the big question is whether large language model can simplify our diagnostic errors in that regards. And this was a very interesting study published a couple of years ago in JAMA. And what they found that the use of large language models can help out reduce the discordance to a great extent. And one of the more interesting things which are happening now is Glass Health, which has developed an ambient clinical decision support. So what you have to do is to just put that support system. It is going to listen to what you're discussing with your patients, come up with a full summary, and then also suggest the likely diagnosis and workup. So this is something which is going to change the way clinical practice probably happens in 10 years from now. So all of you might be a bit concerned as to whether this technology threat can be quite harmful for us and whether we'll be replaced by the machine. This is my favorite slide when we compare AI versus human brain. Our brain is doing 10,000 more steps at the moment, the size of 1.4 kilograms as against a server of 150 ton at that point of time, with only 20 watt of energy consumed, while the machine will take 10 million watts. So clearly we are at least at an advantage now. What will happen in 10 years, 20 years, 30 years is something of anybody guess in that regards. So while AI is evolving in terms of all aspects of medicine, we need to keep human in the loop, develop assistance strategies, and do regulation to ensure that we have got an excellent outcome in that regards. Our team is developing intelligent EMRs, which will help in terms of personalized pediatric endocrine care, developing meal sensitive insulin boluses, which are looking at many more parameters other than carb counting, looking at school health in terms of screening quickly using technological tools, and developing a tool specifically for children, health buddy in that regards. I'd like to acknowledge my entire team of my teachers, my team, and technology collaboration. Once again, I have to thank the organizers for inviting me for this wonderful session.